we're officially starting. I want first just to put this in a little bit of context. Uh, First of all, just for the video, my name is Natalia Sucre. I'm the reading and writing librarian at MCNY. So this is this talk has sort of two reasons for being. One is that it's part of this series on the New York City Racial Justice Commission that we were doing, which is charged with finding ways of reforming the city charter and proposing those changes as ballot measures for the 2022 elections. So we thought it would be interesting to sort of watch that process, and it has been. One of the areas that they focused on way back, I think in September. They started in March. In the summer, they were very active doing listening sessions with people, although I was seeing emails all the time. I don't know if any caught you guys. And then in September, they focused on 6 different areas of inequity. And one of them was quality in services. And I thought that that was an area that would resonate with many of MCNY students who are working in the fields of in city agencies, in community health, in non-for-profits, that who are working in sort of service positions. So, and then I remember Lorna and Michelle, I don't know if you were at the talk with Shamala Rose last summer. I think one of you, okay, yeah, and the issue of Black maternity care came up. I think Lorna, it may have been you who brought it up. Anyway, I don't remember who it was, but it came up as one of the areas that people were passionate about. And so I thought that it was a good idea to focus on that. I reached out to Shamala Rose again, and I don't know if you've heard, but Jamani Williams, the public advocate, is now putting forth a whole campaign to really get something done on this. And it's very personal for him. So he and his wife are having a baby now under really hard circumstances. Yes. I remember watching the interview where he announced that. It was really moving. So that's why we decided to focus on this. So the idea, unfortunately, we couldn't get anyone to come this time, an outside speaker, but what we thought we'd do is watch this documentary that's 16 minutes long, and then just talk about it. Does that sound good to everyone? Yes. Okay. All right. Sorry, I'm going to start it over.
So excited about starting this new chapter and becoming a mother. She would come to me every week. The baby's the size of an orange. The baby's the size of a troll doll. Things like every week. To be quite honest, I was frustrated from the very first appointment. The OBGYN was asking about our marital status. Amber told her we're not married, but we have plans. The OBGYN kind of like gave us a look. She's having a shortness of breath, and she's starting to feel a weakness in her fatigue. COVID is starting to peak, and she's trying to leave work a month early. And she voiced those concerns to her OBGYN. Her OBGYN looks at her and tells her, "You're not the only one that's pregnant going through this. Why do you need to leave?" Leaving her second trimester, coming into her third, which is a nightmare. She always had to stop and catch her breath and sit down. She was feeling dizzy, and we were terrified. We're not being listened to. We're not being taken serious. We're not being heard. Her platelets are dropping, and we're not made aware of this. They're strictly doing telehealth. We were supposed to have a high-risk appointment that got canceled. No matter how much I'm advocating for her, she's advocating for herself, it doesn't change anything. We felt it was racial. We felt Amber wasn't being cared for because she was a Black, unmarried, pregnant woman. So we found the perfect midwife for us. She's understanding why Amber's feeling so weak and, her fatigue, and because her health is deteriorating. So she's telling us that we need to go get medical assistance immediately. They called Amber's time of death at 12:36 past midnight. She really died as soon as she gave birth. The first thing that they tell us is, we're sorry for your loss. I lost it. I'm getting flashbacks of all the negligence that stemmed into this. This is their doing. They dropped the ball on this one.
Black women are 3 times more likely to die in childbirth than white women. The system was never built for us to thrive in it. This is something that is institutional, is cultural, is just a part of the fabric of America.
No, making good progress. Yeah.
And so how do we push back against that? How do we create healthy families? How do we turn back some of these poor outcomes, these stressors that people are experiencing? And I think it does have a lot to do with the care that we provide. And growing more midwives in our community is going to really change the maternal and infant outcomes that we have been seeing.
Birth culturally always has been managed by, women caring for women. What's interesting to me about my great-grandmother is that, she was the first person in her family line that was born outside of slavery. She learned midwifery from her mother, who had been midwife as a slave. I would often sit with my grandmother or my great-grandmother, and I got to hear people and watch people pull up to the house and, come get my granny because, so-and-so is sick or so-and-so's in labor. And so that was my reality of what midwives were. They were experts, they were knowledgeable, they were highly respected. It wasn't until medicine decided to start professionalizing itself at the beginning of the 20th century that suddenly midwives were a little bit of a threat.
It is not the force, but it is the man behind the forces that counts.
When they were trying to develop obstetrics as a specialty, the way for obstetricians to get better at birth and at surgery and at all the obstetric procedures would be to have access to large populations of women to care for over and over again.
This instrument is one of the most beneficent gifts that the art of medicine has given to humanity.
That sense of profession starts to become dominant, that we are obstetricians, we are the specialists in childbirth. Hospitals themselves go from being places where only the very poor went to places of science. The one place midwifery persists is in the Deep South, because white physicians might not be willing to attend births to Black women, and hospitals themselves were segregated. And so women couldn't go to those.
Basically, every state developed a regulation process and began licensing. But one of the downsides to that was this demonization of the midwife, and especially what they called the granny midwife.
2 days ago, a baby delivered by a midwife died when it ought to have lived. My examination showed that his cord got infected, and you all know what that means. Something wasn't clean. Maybe the midwife didn't boil her scissors long enough.
Especially in an era when white supremacy was very prevalent, when, Jim Crow laws in the South are controlling how Black people can be educated and when and where. If you say that every midwife is required to complete these documents on every mother that's registered, but her literacy is limited, and then that's a barrier. You may have had someone who had delivered every baby in a county, but all of a sudden, if she couldn't adhere to those rules or wouldn't adhere to those rules, she was now, essentially criminalized, or at least, a renegade. Part of what led to the elimination of midwives was just by stereotyping people as ignorant, dirty, illiterate. The fact that this workforce was mostly Black women, and that those that weren't Black women were immigrants. This really was about race and class.
Over time, nurse midwifery became recognized as a profession. Nurse midwives are now being formally educated in a university setting, where for most Black women, it was out of their reach. I entered midwifery school in 1980. It was overwhelming white. I always knew that I wanted to go to Harlem Hospital. I was going to be the best midwife that I possibly could, and that's exactly. The struggle was just to prove that we were a legitimate profession, and we had a right to exist and be. Over time, however, that changed. We became more integrated into the institution, into the department. Midwives show decreased cesarean section rates, lower preterm birth rates, higher breastfeeding, higher bonding, just higher any parameter that one would ascribe to having better outcomes. Integration of midwives contributes to that.
There are studies that compare what happens when you have low-risk cases dealt with by obstetricians and low-risk cases dealt with by midwives, and generally midwives do better. It's part of a system where there'll be referral of higher-risk cases to obstetricians. But great, that's exactly how it should be. For high-risk cases, you absolutely want to have the highest trained obstetrician possible. But the fact of the matter is, for most women, they don't need that. The challenge in the United States is we built up this system around obstetrics, and systems don't change very easily and without much pain.
You've got to develop a relationship. It's the relationship that's the most important thing, and that's what the women got. They got a relationship that was not affected. It was genuine, and they knew it.
If we're going to try to address the problem of racial disparities in outcomes, midwifery is, in one sense, really prepared to do that because of the nature of the care they provide. On the other hand, midwifery is an overwhelmingly white profession at the moment. And so there's a dire need to diversify the profession itself if it's going to reach those folks who most need it.
Before we were Black midwives, we were Black women, and we have the same shared living daily experiences that these women have. That's what Black midwifery brings, and that's what's different from midwifery in general.
I decided to create a midwifery practice in Memphis because I thought that it could really shift the outcomes that we were seeing in terms of maternal health and child health. Memphis is a predominantly Black city, and it's also a poor Southern city. There were not as many providers that looked like us. There's a lot of mistrust in healthcare, especially in the Black community. Women come to us with stories of being mistreated and not heard, not listened to. Breastfeeding is going okay? Yes. What we're seeing is that women and families are demanding midwifery care and out-of-hospital birth. But accessing out-of-hospital birth options for families can be hard. when we decided to start midwifery services here, one of the things that we knew we would do was to center Black and brown families, but also to center families that were on Medicaid. On the side, start at the top. Tell me what you feel. I wanted to also be a training space for Black midwifery students and to develop this center of excellence. To me, it was important to grow a workforce and to restore Black midwifery to the South. Hello, how you doing? Good to see you. Our work is not just in caring for, this pregnant person and caring for this baby. So how you feel emotionally? But really to help them through all stages of whatever it is they to, to care. I remember when I first met Rhonda, she started telling me about her birth story and how her water had broken, and she had told her provider that her water was broken, and they did not believe her. They kept telling me things like, "Oh, you're peeing on yourself," or, "That's normal." And I'm like, I don't think that's normal. Like, my water has broken, and I knew that that meant that was basically on a timeline that I needed to have him delivered to make sure that he was safe, I was safe. We ended up in an unplanned C-section. So it was almost like an emergency was induced on the situation. I really thought that me being a nurse, people would listen even more, when I was saying, things were going on with my body or with the baby. Just the whole process made me have a lot of anxiety. And so it just really messed with me for a while. And so I knew that if we got pregnant again, that we would want a completely different experience. Contractions are working. They are doing something. Right? And the fact that they then space out, that gives you a little bit of time to rest. And that's what we should look at it. From the time I went into the appointment with Nakia, I really felt like they wanted to make sure that me as a person was okay and not just that the pregnancy was okay. Give us some deep breaths, Mom. Deep breath. Whenever somebody is really listened to, it makes you feel validated. It makes you feel worthy, like, you're worth listening to. This time around, I know that I'm able to advocate for myself. And so even though things were progressing slowly, there was never any anxiety, there was never any fear, because there was so many people reassuring me that this is normal, everything is going right. It really has become a village of families who come together and support each other. And I think that's how it was before midwifery. It was communal. And so that's what we're seeing now. We're seeing a return to that. As soon as the baby was born, I was almost on this euphoric high almost. When I saw her face, I cried. I felt like that was really my redemption moment, my time, yeah.
Hi. So I thought everyone here, hi everyone. Thank you for coming. You're all from, is everyone here students from community health, student and alumni? What fields are you in?
Healthcare management systems.
Okay.
Michelle and I are from the community health. We're alumni.
Oh, right. Okay. Yeah. And Miss Blue? Oh, maybe she can't unmute. Oh, no.
I'm in medical coding and billing.
Okay. So all in the medical fields in some related to healthcare.
And
Okay.
I'm actually a doula also, but I'm not practicing at the moment.
Oh, Fiona. Oh, wow. Wow. Would love to hear more about that.
Yeah, when you're ready, just let me know.
Okay, okay. I thought maybe we could just go around just to hear everyone's voices to begin with, and just react to this video. What stuck out for you? What was you're viewing this in a much more knowledgeable way than I am. So what resonated with you? Fiona, you want to start?
Hello, everyone. My name is Fiona. And what resonated for me is that in a country that is so rich, America, women are dying at faster rates in childbirth. And it's not seen as a celebration, it's seen as a medical problem. And it's almost like if a woman has an issue in pregnancy, well, you know what, we must put her here. She must be boxed in. And that is not fair to women. The program that I belong to is actually based in Brooklyn, and it was created for young women who had no parental involvement in their childbearing stages, because what was happening is that a lot of the young women, they were being abandoned by their parents and family members when they get pregnant at an early age. So the doula program was actually created to support those young women who didn't have any involvement. And you know, it surprises me as an immigrant to this country that childbirth is such one of these things where it's just, I don't get it. And I myself experienced an issue when I was having my daughter about 27 years ago. And, you know, and
here in the States?
I had her here.
Yeah, okay.
But compared to deliveries in my country, it was so much different.
Right.
And I also happened to work in an emergency room at one of the major hospitals here. And there was an incident where a young woman came in postpartum, and she had a high blood pressure, and she was made to sit in a room and died an hour later because her blood pressure was not validated just because she had a baby. And this was a Black woman. So pregnancy on its whole is not validated. You know, it's like, oh, and then, you know, I hate to say this, but then Black women are seen as heavier, or we are seen as we should carry pain more than anyone else.
Right. That's exactly what came through in this and in so many other accounts. Yeah. Hi there, Desi.
And you know, when I saw this came on my email, I was like, I have to be here. I mean, I have homework to do and I have finals to do, but this was important to me to lend my voice to it and to also collaborate with other women to see, you know, in our small knit group, what we can do to help others. You know, it's not going to take a month, a year, a day, but you know, if we start somewhere, at least we can, even if we can help one girl.
Right. Right. Thank you so much.
You're welcome.
And and I would really like to hear more about how you became a midwife and all of that. But
No, a doula. A
that's
doula.
a doula. I'm sorry, I equate the two terms, so that there you go. That shows my
That's fine.
ignorance in this field. So even the distinction, knowing about the distinction would be interesting. Yeah. Lorna, I saw you nodding your head a lot. So do you want to go next? We're for those well, Professor Robinson, you're just joining us. We're just We're just going around. We just saw the video, and we're just going around introducing ourselves and saying what resonated.
Okay. Hi, I'm sorry to be tardy. I'll wait my turn.
Yeah, you probably have seen the video, maybe. No. Okay. No.
You know, I have to say at first when I got the invitation, because as I mentioned, I just had a myomectomy on Thursday, and I was like, would I be able to partake in such a discussion? But I'm like, Lorna, you have to do this because it goes hand in hand with my situation that I went through. 12 years ago, I was diagnosed with uterine fibroids and having to go through it for the whole 12 years, and finally decide on Thursday to have a myomectomy. So I feel so compelled to be a part of this discussion. And apart from watching, after watching the video, the story of the young man where his girlfriend died resonated with me so much because I was following the story. And you know, it saddens me that a country as diverse and rich and rich in culture and wealthy as America, that today we still have women who are, you know, the rate is so high, who are dying, you know, because of lack of communication with pregnant women. You know, it seems to be that there is this constant belief that because we're Black women, you know, that we're able to withstand pain, and, you know, we're able to withstand certain aspect of being pregnant. And the truth is we're not. We're just human beings, you know. And I think, you know, it's a serious drive, and it's a serious area that, you know, we need to look into, and just to, you know, help Black women on a whole. And you know, we have to start that conversation. I'm strongly big advocate for that.
Thank you. Michelle, would you like to go next?
Yeah, so what resonated with me with the video is just the, it just seems like it's constant that, you know, as a Black woman, that it's ignored, you know, like the feelings are ignored. If you're, you know, if you're sick, if you are pregnant and you're having, you know, whatever your contractions, whatever your symptoms may be, everyone is different. It's like the young man said, oh, that's normal. Or the woman who's saying that she knows that her water is broken, and they're telling her, oh, maybe she's urinating on herself, as if like anyone else who possibly would be in a situation that, you know, is pregnant. You start to do your research, you might read, you hear things. It showed in the video that going back years, you know, this is what Black women did. You know, we nursed ourselves and nursed our communities, and we were the doctors in the communities. And it still resonates now that, you know, that you're ignored, you know, when certain things, when you go to the hospital, you might be, I can give even an example. You're in the hospital, they come in sometimes, and, you know, people are just touching, you know, your medication or your IVs. They're not introducing themselves. They're not saying, okay, I'm giving you this medication, or how are you feeling? I'm doing this. It's like, it's a regimen. And it's like, there's not a lot of, you know, questions that are asked. For myself, my mother's a registered nurse, and anytime, like if I'm in the hospital, I have 2 children, she's always silently watching, and she's corrected people on more than one occasion. And, you know, just saying, well, you actually connected the wrong, you know, IV, or she's, you know, she's watching, because at that time, because she knows that the value is not there. You know, this person just, you know, had a baby, you know, you need to explain, you know, certain things. And it's just, it's something that has to be, the education has to start because everyone doesn't have that luxury. The education has to start from young. These are what the symptoms are. This is how, you might feel like, like this. You may feel like that, just different things. Ms. Clark spoke about high blood pressure and the person passing away. I work in child welfare. There's someone that, she was pregnant, her child was going to be removed, but there was no compassion in the fact that she just had a child. The baby is going to be removed from you, but mom is still in the hospital, child is still in the hospital. So why remove the baby? And, it had to be stepped in and said, no, until the mother is leaving the hospital, the baby is staying with the mother. And the mother's blood pressure, it was astronomically high, like she could have died. But your blood pressure is elevated because you've just given birth, then your blood pressure is elevated because you're under the stress that your child may be removed for whatever the reason might be. And just that separation. So now what about the child? So the trauma starts there. The child is being ripped away from the mother at such a young age in the first couple of hours. So, other, higher ups had to be brought in to stop that process until the person is physically leaving the hospital. So those are the type of things that get overlooked and that, they're not taken into consideration, a lot of times, and it causes more trauma and it causes more stress and it causes more death. So the education has to start and the conversation has to continue.
Yeah, thank you. Would anyone else like to respond to the video and introduce their relationship to this topic?
I guess I can go. Oh, you want to go, Desi? Desi, go first. Go, sweetheart, go.
Okay. How are you doing, Joanne? Hello, everyone. It's so wonderful to see these faces on this call. I apologize for being tardy. I always sort of sing the praises of Zoom because I can participate in so many more things during the day without being overwhelmed. And then I oftentimes find that I have overwhelmed myself with Zoom calls. And so it's a pleasure to be here. It's wonderful to see a couple of my really star students coming in on this call. There are so many, things that resonate for me. I didn't see the clip, but some of what was referenced sound familiar to me, which I may have seen in other clips of like congressional hearings with families who have lost their wives or children. I've seen too many of these stories. And I think it speaks, when you pull the lens back, it speaks to a much larger issue around socioeconomics, our racial disparities, which permeate every area of our lives. And so there is a saying that, if the country has a cold, Black people have the flu. And so it's really unfortunate to see that for advanced nations, that the United States has the worst maternal rate of health for women. And that rate is even more dire for Black women. What I think is also very telling is that those rates really go across the board in terms of socioeconomics. And so we're not just talking about Black teenage girls or poor Black women in the Mississippi Delta. Mm-hmm. We're talking about middle-class, educated women who in most areas of their lives have the ability to have agency for themselves. And they still are finding themselves within a medical system that doesn't take their pain or their words seriously. And so I think this, for me personally, as a health educator, as a person who has worked in media and has elevated stories around health and politics and education, all of them intersecting in some way having to do with, again, race policy, education, gender, queerness, there is always a resonating theme of the ways in which Black women are treated and the ways in which Black women are valued or undervalued in this nation. Yet we are continually expected to be the bridge and the back in our workplaces, in our families, in our communities, We stand up for Black men when they're shot and killed in the street. We're the ones who are marching. We're the ones who are organizing. We're the ones who are putting forth culture. Everybody wants our Black girl magic. Everybody wants the rhythm, but nobody wants the blues. And so anything that is great and strong and sassy and serious and wonderful and flavorful comes from the body and the womb of a Black woman. And yet we are the ones who continually, Black women, Indigenous women, brown women, are the ones who are continuously forgotten and undervalued. And so these conversations, I think, are so important. And when we come to the table, we're usually preaching to the choir. But what we have the opportunity to do as educators is to be able to propagate the importance of these messages. And I'm so proud of Michelle, and I'm so proud of Lorna, particularly after having had her surgery and came on. And I knew that this would resonate with them. And I'm so happy that they decided to come. And I'm so proud of Lorna. So much of the work that she had done in her research in our last class had been around Black women's health. And so she's doing really great and amazing things to continue that work. And having those conversations and being part of the MCNY community has actually led me to this very epiphanal decision to be a doula. And so I'm going to be researching some training. And actually, when I came in, heard Ms. Clark talking about being a doula. And so I think that is something that I would like to augment my portfolio as a health educator around. And it's a piece that I can contribute to this conversation around improving the lives of women, and particularly Black women.
Just to add to what you said about women and their status, Serena Williams, who is a multimillionaire,
the most.
She went to the emergency room and they ignored her.
They ignored her. Even Beyonce had maternal problems.
Yeah.
Yeah, I think we were just mentioning that even women who have the deepest sense of, power and recognition are still experiencing Black maternal health issues.
And just to add into what Michelle said, hence the reason why health education is so paramount, because sometimes no one should be blamed because of the lack of information, but the people who are able, to provide this information, hence the reason why it's essential that we, educate our Black women and teach them how to advocate for themselves, because, sometimes Black people, we tend to be a bit shy in terms of standing up and being, I'm in pain, because society, already put that on us, that, we're strong and we're able to withstand whatever pain that we're going through. So hence the reason why, again, health education should be top priority as it relates to maternal health.
Lorna, I agree with you.
Oh, I'm sorry.
I think also the healthcare providers need to be educated, right? There needs to be diversity training. There needs to be sensitivity training. There needs to be training where you can start to see your own biases. I'm Dr. Artavini. I'm the Dean of Human Services at Metropolitan College of New York. And this topic really touched me close to almost 22 years ago when I was pregnant with my twins. And I actually went into labor while I was teaching a class. They were 2 months early. I was living in Texas at the time, in Huntsville, Texas. And my gynecologist quickly, ambulance, they jetted me down to Houston to the Texas Children's Hospital, where there was the intake for high-risk pregnancies. And I was in this limbo room with another woman who happened to be a woman of color. She was a Latina, and she was not doing well, and her pain was great, and it made her so nauseous, and she was throwing up. And I just so sympathized with her. And every time the nurses would come in, they would just placate her, and if I heard once, I heard a million times, oh, women have babies every day. That's all they would tell her. And, you know, we deal with high risk pregnancies here all the time. And by the like the 6th or 7th time, I just had enough and I said, yeah, they may, but she's having a baby now.
Right.
This is her experience. Identify it, take it seriously. It's not normal to have such a pain that you're throwing up, you know? And it was to the point where then the nurse just rolled her eyes at me. And I was just like, no, not in my presence. It's not going to happen, you know? And I was petrified because I thought, is this the treatment that they're giving? And I'm petrified for myself. It was the first time I had children. I was two months early, thinking what could happen to my children, and am I going to make it myself? And then looking at this other woman, thinking at least they're validating my experience. They're saying, oh, we know you're in pain. Right away, I was put on the magnesium and stuff, and I was being watched, but she wasn't getting that same level of attention that, as a social psychologist, sociologist, criminologist, I was like, this is criminal. She's here for healthcare and you're ignoring her. Like, it just was to the point where, you know, when they said that they could move me, I like asked her first, is it all right? Because she kept thanking me, you know, take her seriously, do whatever you bring for me, you bring for her, kind of thing. And it was, I don't know what happened to her after, because then I was brought somewhere else and the magnesium, you know, basically paralyzes you. So I was out for a week until finally they realized it was okay with all the hormones they shot me up, that I can actually have my children. They were born, as soon as I got off the magnesium, labor and delivery was 2 hours and 40 minutes. They were born a minute apart. Luckily, they were both 19.5 inches, about 5 pounds each. One of them now is in our MPA program, so they're okay. But it's through the grace of God and my skin color that I can honestly say that I was treated differently than this woman. And to see, when I heard about, you know, Serena Williams and all these other, I was like, still this is going on, you know. The education has to go on both parts. I don't want to always put the onus on the patient, right? We're coming to someone for help. This is your area of expertise. Take us seriously. And, you know, it is all women. We see as pregnant women are, sadly, we celebrate them, but then we push them to the side as well. We marginalize them. And it's just, it's repugnant. It really is. And it's like something has to change, because I fear that one day my daughter will have children, and, you know, the way my family pumps out twins and triplets, God help her, but you know, it's we'll see. But thank you very much for bringing this series to our attention. I appreciate you all, and you're in my prayers, Lauren. I hope you're feeling better.
Thank you so much. You know what, I must say, I'm stronger than I thought. So thank you. Thank you. I appreciate it.
One of the things that really dawns on me is I've always been a real advocate for comprehensive sex education. And as an educator, I used to run an after-school program, and we had a few different programs ranging from robotics to sex education. And it was interesting to me how many parents had opted out of their child getting that. And the excuse is always, oh, well, I'll teach my children at home. I don't want anybody else teaching my children this, and, you know. And then what always happens is they never really teach them at home, right? And so I think that there's a wide-ranging benefit of having comprehensive sex education. One of them is not only for women to understand their body, their pleasure, their changes, and all of the things that make it really important to have great and deep sexual agency. But also as it translates to being able to communicate with partners and making sure that they understand who we are and they understand what is going on with our bodies. And there is this ignorance on the part of men, cis men, gay men, you know, folks who walk the life of of male privilege where they sort of get a pass because they don't understand how women's bodies work. Oh, I don't understand how that works, and they do it, for lots of different things, whether it's folding a sheet or understanding our body. They're able to have this kind of deniability that removes them from having to be responsible for understanding who we are, what our bodies are, what our emotions are, and all of the things that go along with being a woman. So that's problematic as it is. But what makes it deeply injurious to us is that they are oftentimes the one who are in the most power, who are legislating policy on what happens to our bodies. And so we can't continue to let 50% of our population get away with this kind of ignorance because it's not their business or it's not their problem or whatever reasons we make it okay for them to not know what it is or understand what it is to be women. Because believe me, if we were having reproductive conversations about Viagra, these conversations would go very differently. If men had an opportunity to take a birth control pill, Gloria Steinem said they would come in various flavors. And so the onus, as Joanne said, is not simply on us to have this sense of agency to stand up for ourselves. We have to educate our broader population from everything about how our body works to what becomes necessary in the workplace to be able to be a parent. The absence of understanding women and women's bodies and women's reproductive rights has a really deep spanning and expansive impact. Everything, as they said, from the cradle to the grave. If women are expected to do all of the things that we do and be parents and be in the workplace and then also make less money for doing the same thing, and if you're a woman of color, even less than your white woman counterpart, that has a deleterious effect on the ways that you retire and the decisions that you make, when you're not working. If you look at sort of global statistics, the largest factor in poverty in women is parenthood. And I mean, I could go into the economics of, the pink tax of what it is to live in the world and have to pay, pennies more on the dollar for things that men get. You want pink Legos, it's going to cost you more than if you get regular Legos. If you want a pink razor, it's going to cost you more than if you get a blue Gillette, even if those razors are made in the same company. So I think that this particular conversation is connected to so many other ways in which women, and particularly women of color, are continually beat up in every corner of their lives for not having the equity of men in our society. So the education can't simply just be on us. There has to be a larger, more wide-ranging understanding about the importance of women's health.
Thank you. So, go ahead.
Can I just say one thing? I absolutely, I agree with Professor Rob, and I just wanted to add, and the whole thing with the education piece, and even with, going back to what she said about running a program and asking parents, about sex education, or even if it's in a school, what normally happens is that people equate sex education with sex, act of having sex. Yeah. And this is why parents and, even some, can be an educator that's not prepared to do that type of presentation. They don't want to deal with that conversation. They don't want to have that conversation. And this has been going on in schools, for forever. Teaching someone about having sex education, or now gym class now is not as physical as it used to be, which would be, you know, playing sports and so forth. Now they're doing, you know, sex education, or they're doing health education, but it's not as broad as it needs to be. So now they're going into, they want to talk about nutrition, which is important. It's all part of it. But what about learning about, you know, your body, learning about, you know, different aspects, different feelings, becoming mature? That all plays, you know, a part of it. It all plays a part of it. And until we stop like sweeping it over to the side and, you know, a parent, the conversation could be, okay, I mean, we can't tell people what to do, but how come, let's have a conversation that, okay, so this is part of the curriculum. If we're not going to do it, you're welcome to teach your child at home, but how are you going to do that? What does your playbook look like? Because it's not, I think a conversation should be held that says, you know, sex education is not about intercourse. No one is teaching your child to, you know, but it's about, number one, what's the possibility if it happens? Number two, just knowing away from that part, just how to take care of yourself, what to look for. So it's still something that's being, you know, brushed under the rug as something that's like, well, that's not important. Oh, sure. Oh, mom, you want to teach them? Dad, you want to teach them? Great. Now it's out of our
What do you
hands.
need? Well, how can we support you in that?
Right. You know, but people are, you know, we can't keep pushing it under the rug. It has to be addressed. So I definitely agree. You know, I agree with that. Definitely.
I had a sex education class when I was 11. I was in a pilot program. It changed my life. It changed my life. It gave me the deepest sense of agency over my body. And I felt like I could make decisions that peer pressure, that no level of peer pressure was going to sway for me.
That's interesting. It's interesting that you said that, because just one more thing. I'm sorry. Just it's interesting that you said that about having a sex education class when you were 11. I think I was around 11 or 12. I was in Catholic school, so you know they did not want to talk about anything that has to do with sex. You know, so but the conversation came up, and we had a teacher. And she was already a mom. She had like maybe I think she had 4 children, and she actually volunteered to do that sex education class. And it was like, we knew, I mean, like, again, everybody doesn't have that luxury. Like, I knew because of my mom's profession and, you know, her always exposing and, you know, letting me ask questions, but being able to discuss as a young girl, being able to discuss it with other, you know, students and kids that are your age, it changes things. And a person that you can ask questions, you know, other than your parent, you know, I mean, I was comfortable asking my parent, but that part was important. So I understand exactly what you're saying when you're saying that it empowered you. So, and that just proves that it's a positive thing.
Yeah, I just wanted to say quickly, it really resonated with me, what you just said. It sort of explained the whole education piece, that they brush it under the rug, right? That with the sex education. And that's exactly what they're doing in this situation with Black maternity care, right? So in a way, the sex education and the education of the patient is about agency, right? It's about pushing back against that being brushed under the rug. But then the other side of it is what Dean Ardovini was talking about, the education of the caretaker. And in the legislation that is being proposed, there are many aspects of it, and I can't say that I understand all of them, or I've looked at all of them, but one of the big ones is bias training. And what I am curious, you know, we all get sexual harassment training, and you sort of brush it off sometimes, you know, like I wonder, like, how can that training, what do you all think about that training? Is it effective? How can it be effective?
I've published in the area of sexual harassment and sexual harassment legislation, and going through the training myself, it's rather a joke, because I think people go through it as quickly as possible just to get through it. It's just an exercise just to get it over with so they can get the little certificate and say that they did it because HR told them to do it. But when you see just the treatment that people think is the norm, right? Because we think in these dichotomies, right? We're either a cancel culture or we're over to the other end, right? So everything, there's no in between. No, I can't tell a young woman that, you know, she looks nice today because she'll be offended. No, you know, that's going to the extreme. Let's get over this. But if we're going back to the discussion of knowing our own bodies, we have to also put it within a historical perspective, that it wasn't until the women's movement, the feminist movement in the 1960s and 70s, that women started to talk about these things. Like, you didn't talk about your body, you didn't talk about enjoying sex, because you were, as Andrea Dworkin's, the feminist writer, talks about how epistemologically, you are a vessel for a man's pleasure and a man's pleasure only. You're not supposed to take pleasure in that you're not supposed to know your own body. So, and the extent that men know our body only in reference to how they could use it to please themselves, right? It's not what they could do. So it's moving forward. I you know, even having my children that are approaching 22 years old, you know, we have open dialogue and discourse about, you know, sex, and you know, ever since they were young, whatever questions I would try to answer as honestly and as much as I you know, as I could. And being a victim of Catholic school myself, you know, when my children would talk about, you know, masturbation and are they supposed to feel guilty about it? And I said, yes, we're Catholic. We feel guilty about everything. And I just like tried to make a joke about it. And I said, no, because you know yourself better than anyone does. And then it's up to you to also share that information with your partner, not only sexually, but when you're not feeling well, try to explain what it feels like. So that later on, I tried to have those conversations with my husband at the time when I was pregnant, my ex-husband now. But it was letting him understand. So when I would look at him and I would say, you know how I'm feeling, like I told you, and he would say, yeah, this is how she's feeling. So it's like you have two, you know, you have someone on your side fighting as well. So the conversation needs to be there. Many times, though, we also have women that are having children on their own, and like, who do they have with them? You know, how do they move forward? There's all sorts of, like I said, we have to start with just the epistemological thing to understand how we view socially and culturally each other's bodies, how we understand those things, before we can get to the true, honest legislation that would make a difference. Because if we're going to have this legislation, and it goes back to, does legislation create the culture, or does the culture create the legislation? Right? So which one do we go? And at this point in time, I would have to argue, even though I just said that we need to know epistemologically, you know, to try to change the culture, people's lives are in danger. So we need the legislation first to force the change in the culture. But as we're doing that, the education must occur. And there has to be open dialogue when it comes to sex education. We have to just not think it's just sex intercourse that we're talking about. We're talking about everything, the body parts, what they're called, and stop using, you know, child names for the body parts. You know, call it what it is. The only time I refer to a child body part is when I'm referring to my dog's body parts. Like my dog Mitchell has a peenie, right? So like, because it's a dog, right? So trying to use some humor, but other than that, when I spoke to my son, it was your penis, right? Your vagina, this is the parts, this is how you clean yourself, right? You know, and having that open conversation. I think my son actually just said this. He came home this past weekend and he said, I think I have more of an insight of a woman's life because I grew up with just you and his twin sister. So we were very open about those things. He goes, and I listened to some of my teammates and the way they talk about women, and he's like, what do you guys, like, were you born under a rock? It's like, in what world? So these are all things that we have to start. And yes, it does have to start at home. And schools need to buttress the whole thing. And I will get off my soapbox because I see that it's 7:06.
It's 7:06. I want to say that it's very possible that we will be having more conversations on this topic. There may be someone from the Public Advocate's office coming to talk. I won't say who. We'll leave it at that. But what would be amazing is if some of you, with your experiences in your field, with your experience being a doula, with becoming a doula, if before we have those conversations, we can reach out to you and maybe have a way to prepare for that other talk, so we can continue this conversation. And I had prepared a bunch of links that I'm going to send to you guys, just because I think they're different interesting information and about the legislation too. So this was a great talk. It was so great to hear you all. And it's just the beginning completely.
It sounds great. The other piece that I think is really important is that I love the opportunity of pairing with students and staff and professors and administrators to have MCNY be at the forefront of this conversation in our communities. Like, I love the idea of Metropolitan College of New York being a hub of community development in all ways. And if this is a way that we can lead a conversation in the communities in which we serve, I think that that's really excellent. And I'm proud to be a part of that.
And to piggyback on that, even if we can create a flyer about women's health, and in the admission packet when it's mailed out, or even put it on the intranet so that everybody else can see it. And then we can extend the invitation to some of the men on the faculty, so that they themselves, as fathers, as godparents, as uncles, they can also educate the young men in their lives. You know, sometimes we exclude the men, but sometimes they have more access to other individuals and to other women.
And they need to know.
Just to quickly add on before we depart, I had to share with you guys. So I'm all in of this initiative, and also based on my experience with uterine fibroids, I've now created a social media campaign awareness, and I can tell you guys, it's amazing. I'm overwhelmed by the amount of women who was silently suffering because of uterine fibroids. And because I shared my story and my journey, so much women now know the signs, the symptoms, how to have a conversation with their doctors, what to look for, what to ask. So there you go again, health education should be the top of our list forever.
You're right. My daughter is very much, she suffers from polycystic ovarian syndrome.
Wow.
So those are issues that we are constantly dealing with, because the medical industry right away, medicate her, put her on medication, instead of trying to look at a holistic perspective. Let's just shoot her up with a whole bunch of hormones, or try to, you know, and you know, she's just lucky that she, you know, she's a smart young woman, but she has an educated mother that can push and do the research to find out what are some other things that you can do before just right away giving you hormone shots and all this other all these.
Absolutely, absolutely, yes.
That is so amazing, and it is a form of education that is relatively simple now. The social media, and it's just so powerful to hear that. So another thing I'd like to ask is, I'm assuming the answer is yes, and I'm assuming many of you are already connected anyways, but can I do a Google group, an email group of you guys, so that, I mean, these are amazing ideas about the flyers, even about maybe doing some social media. I think that it's in the spring that it's the month for Black Maternity Care. So we could do a campaign then. We can certainly invite the community into talks as well, if that works. So yeah, this has been really great.
Yes.
Whatever you need, Natalia, you have human services will support you.
Thank
We'll
you.
put something on our website, and I don't know if those of you know that I'm venturing into being the TikToking dean to get out the name of MCNY. So that might be something that we can do, you know, a 1 minute to a 3 minute thing and send all that information out there. I'm still trying not to spend the money. I'm trying to figure out the algorithms myself, because they have a thing where you can pay TikTok and they'll do the algorithms for you. You know, we don't have the money for anything like that. So I've been trying to do this, run the statistics myself. I'm such a nerd, but you know, so far I think I'm cracking it just a little
Well,
bit.
then you can let everyone else know and put it out.
It's not that
open source.
difficult. It's all the hashtags and the music that you put with it and who you you tag. So
Right, right. All right. Well, on that note, that's a great note.
Yeah. And Black Maternal Health Week or month is in April of 2000. Wait, well, we're going into 2022, so it should be in April.
Right, right. So we can prepare for that. We can start doing things before that, obviously.
You can put the information in Easter baskets too.
I would also recommend bringing in, there's a new young lady whose name I can't remember. Well, I'm calling them a young lady, but their pronouns are they and them. So
Reshma,
yes.
yes, definitely.
And so this
I
might
will.
be something to share with them about, you know, looping in some of our existing efforts into some of the event planning that they're already doing.
Yeah, because we don't want to overburden students with events either. Yeah, yeah, that's great.
It was great to see all of you. Thank you so much for coming together. And these conversations are always really, really great to have. And it arms us with, you know, what we're going out into the world with.
It really does.
Looking at the sea of my faces of my sisters.
All right, thank you.
You guys enjoy your rest of your week. We're moving into hump day.
Yes, and if I don't see you all before the end of the year, happy holidays and safe.
Thank you.
Yeah,
Thank you. Thank you.
holiday.
Let's
Happy
hope
safe
2020
holidays.
is better than the past 2 years.
Yes. Praying.
All right.
Take care.
Take care,
Thank you.
everyone. Thank you,
Bye-bye.
Natalia, for your work.
Absolutely. Thank you.